It's my great pleasure to introduce Dr. P.S.S. Sundar Rao, a biostatistician, teacher for me and for many people, leader par excellence. He came to CMC Vellore many moons ago, 1955 to be exact, and he joined the Preventive and Social Medicine Department, or we call Community Health Department, and that's the photo of current Chad. I couldn't get a photo of the older Chad, and his starting salary was rupees 125 per month. I don't know how he survived on that. He operated the first hand-operated facet calculator. And because he came to the department, actually, they had a large project in Chad, and nobody was able to analyze the data. They had collected volumes of data. So the person in Chad, Dr. Chandy, contacted Indian Statistical Society in Calcutta, and Sir's teacher from Presidency College said, I've got a very good student of mine. So that's how Dr. Sundar Rao came to CMC. And because he was able to reanalyze all the large volumes of data, this fund at that time, the Williams Waterman Fund, which had stopped for a while, it restarted.
We'll take a picture, both of us.
In 1962, after that, Sir started statistics classes for third-year medical students. And I also have listened to, at least in first-year medical student, we had classes in biostats, but it started off with third-year medical students. In 1962, Sir got a Rockefeller Foundation Fellowship to do an MPH in biostatistics at the University of California in Berkeley. He also got the fellowship of the Royal Statistical Society of London in 1962. And at that time, Dr. Chandy, who was our director, recognized that this is the time to have a separate biostatistics department. And Sir was the first founder and head of the Department of Biostatistics. Many major research projects were undertaken by Sir. The most important one of that is what we're going to hear today, the Vellore birth cohort. It was not called the Vellore birth cohort initially. It was called Longitudinal Studies in Human Reproduction, later on renamed as the Vellore birth cohort. At that time, the principal said that it's time for us to have a research committee, and that was the beginning of the IRB. And the principal was a chair, and Sir was, as the head of biostatistics, was the secretary of the research committee. In 1974, he went to the Columbia University in New York, and he did a PhD in biostatistics. When he came back, the University of Madras recognized Dr. Sundar Rao's training and his accreditation, and he and his department started MSc in biostatistics and PhD in biostatistics. And he has published many books. This is the biostats department for those of people who may not be familiar. And that's the book, which is now in the 5th edition. Sir and Dr. Richard, his colleague, have published many books. This is one easy book for research. After retirement in 1994, after almost 40 years of service in CMC, he went to the what we call Karigiri Hospital in CMC colloquially, but actually called the Shefflin Leprosy Research and Training Center, SLR and TC. And he was a director of SLR and TC for 10 years. And that center is now recognized thanks to him as a PhD place. So many PhD scholars come out of that, and that's thanks to Sir. After his stint at SLR and TC Karigiri, he went to Delhi and was a research coordinator and head of the resource center for the leprosy mission. Now, the leprosy mission is a big mission in India globally, and he was the head of the research for leprosy mission for almost 10 years. And he was also a consultant and research director at Lepra India for 2 years. After his stint at the leprosy mission, he is currently an honorary visiting professor at the Martin Luther Christian University in Shillong. So even now he's active as a researcher, and he's guiding many people in research, including people in distant Shillong. His 6 decades of leadership, he's taught, I think, thousands and thousands of students all over the world in biostatistics and research methods. He has several books, and I've shown you the picture, the Introduction to Biostatistics and Research Methods. And he has got numerous papers in reputed national and international journals. He was one of the foremost medical researchers in the country. He has 300 publications plus and more than 100 research grants. Most of us will struggle to get even one or two grants in our career. He's had more than 100 of them. Because of his eminence, he's also been the chairman of numerous committees in the government of India. So, board and expert committee member for ICMR, National Institute of Nutrition, Cancer Registry of India, National Mental Health Survey of India, and the Bhopal Gas Disaster Research Center, and many others. So, truly an accomplished person. He was awarded the Lifetime Achievement Award by the Indian Society of Medical Statistics in 2017. And he's also the fellow of many national and international societies. I think the principal of that is the Royal Statistical Society in London, the Human Biology Council in USA, Indian Society of Medical Statistics, American Statistical Association, and the Biometric Society. Currently, he lives in Bangalore, I think close to Baptist Hospital, sir. And he's freelancing as a consultant, as a mentor and advisor. So anybody here or anybody listening online or in future to this talk on YouTube, you can get in touch with Dr. Sundar Rao, and he will help you with ideas, designing your research, how to collect data, how to analyze it, how to interpret it and write it. So many PhD scholars in Bangalore and all over India, including from Shillong, and DNB students who are medical, including nursing students, come to him for protocol writing, data analysis, and publication. The CMC motto, all his services are free. He's passionate in promoting biostatistics and medical research. And he wants to demystify biostatistics from being a very tough and difficult subject to conquer. He wants to remove the fear and apprehension for biostatistics and research. So with this few words, Sir CV is very long and there are many, many things to say. I knew him from childhood, literally from childhood, and his children are my close friends and like brothers to me. So I'm very grateful that you accepted our invitation to give this talk on the Vellore birth cohort. I mean, it's a phenomenal achievement. People don't realize the level of achievement that it is. We're very grateful to you, sir, for coming and taking this talk for us. So over to you.
Thank you very much, Tambo, for the very elaborate introduction. Just this moment. You can hear me? Yeah. A few anecdotal kind of a things. Find my name, P.S.S. Sundar Rao. My father believed that all of us should have 3 names. So I belong to a family of 9 children. I have 6 sisters and 2 brothers. And my father started his manufacture of babies from 1930 and went on till 1948. So I am third in the family. So just for your information, my P is a family name. It's too big, you can't. But my email has got that Pamidi Pani, which is an honorary degree given to one of my forefathers as Golden Leaf. He was a poet laureate. So he was given that designation, like today we talk about Padma Bhushan and Padma awards. There's Pamidi Pani. But my SSS stands for Samuel Simon Sundar. My father was a Rao, so I added a Rao. Otherwise, it was not there. My coming to Vellore is an interesting story in the sense that when I finished college, my father moved to Andhra CMC had done, I think it's good for you to know the history. For the first time, the entire institution did a community survey in Pennatur village called the General Health and Nutrition Status of the Population of the Pennatur. All the departments, Dr. Brand, Dr. Vaidilingam, Dr. Kutumbaya, they all participated and collected a massive amount of data of each person and a dietary survey, qualitative and quantitative. And they took 20 cc at that time of blood just to estimate vitamin A and hemoglobin. Today, I think you can do it with a finger prick. Having collected this mass of data, which was supported by the fund called, you know, the Williams building you have here, R.R. William and Waterman, they had a fund. Incidentally, R.R. Williams, the second R stands for Ramapatnam. Did you know that? He took that Indian name, Robert Ramapatnam. Anyway, having collected the data, all of you will go through that process when you do your research. You have to analyze it and present a report. At that point, CMC did not have the expertise to analyze. They collected the data, but they could not analyze. So the fund was stopped. And an SOS was sent to Indian Statistical Institute, where some of the CMC staff had a contact. And they asked if we could send a statistician or somebody who can analyze. It so happens, as was mentioned, my professor was there and they asked him, he suggested my name, called my father, and then I was told, can you go to Vellore? I said, sure, wherever you send me, I'll go. So from Anantapur, I took my suitcase and my guitar and traveled by a train via Pakala and Chittur, landed at 1 o'clock on 14th. No taxis. There was one bullock cart, which was the taxi at that time. So I engaged that person for 5 rupees to Bagayam. It took 2 hours traveling from Katpadi. There was no bridge at that time on the sand. Reached Bagayam at 3 o'clock. And I searched for the Dr. K.G. Koshi's house. And the first person I met was Mrs. Koshi. She said, Dr. Koshi is sleeping, but he has arranged a room for you in the men's hostel, room 103. And your food will come from women's hostel in a tiffin carrier, and you have it. So that's how I started on 14th. And Koshi came. And then at that time, we had an American called Roy Allen, who later became the Rockefeller Foundation chairman and so forth. He came and visited me and he said, tomorrow is a holiday, Independence Day, but we have a work camp in a village called Munjurpet. Would you like to come? I said, sure. So on 15th, I went for the work camp, and for the first time, I met some of the staff of the Department of Preventive and Social Medicine. Some of you will know Anthony Palokaran and Sosha Kuruvilla, Eli Kuruva's sister, and a few others. Then I started my work from 16th. There were no computers at that time, no calculators. I asked Dr. Koshi for a calculator. He said, you are the calculator, so you calculate. I said, so much of arithmetic there is to find out calories from protein, fats, carbohydrates, nothing. So, like Pilate, he washed his hands and went off. Fortunately, Dr. Allen came and I told him, at least a hand operated facet. He said, how much it cost? I said, $1,000. So he took $1,000, gave it to me. And then he gave me 20 rupees, go by bus to Madras. At that time, it was 3 rupees 50 paisa. Bus fare stops at Sulkuvar Satram, where you pass your urine all over the place. And then you go to Chennai. Went to Adyar, got the machine, came back, started crack. I did my job. So I think Tambo has mentioned about that. That's how I began. What I want you to remember is that the first cross-sectional epidemiological study of a village by CMC was this study in Pelatur, which has been published in many papers. There was a retired health officer, B.R. Hanumanta Rao, and P.S.S. Rao. We both sat in the room, which is now the interns' quarters. And he used to be a chain smoker of passing show, but he was a good writer. I inhaled all the passive smoke. Fortunately, by God's grace, I don't have any cancer of the lung. But I learned a lot. And while there, I helped in other places, other projects. Do you know Dr. Rachel Mathai? Her first job was in community health medicine. She and Dr. Panaya were involved in a research project on vaginal foam tablets. And so she was also there in that photograph. I'll show you. Picture is there. And Dr. Panaya worked in Kavanur and came. He and Rachel, they took the village of Edenjat and went house to house talking about it. And Dr. Panaya could not say actually to put the vaginal foam tablets in the right place. So he used to say, Saptia, Sapta. Some of them actually swallowed those vaginal tabs and came to Bagaya vomiting and all that. So that is how I enjoyed my life in the beginning. I'm giving you this background because while you're listening to what I'm saying, whenever I talk to a group like this, I expect you to take the essentials and learn the principles, and I would expect you to do it. I hope and pray that all of you would get engaged in these types of studies that I'm going to describe, because you get a lot of satisfaction as a doctor, as a health worker, working with the people. After all the work that you people do is for them. They are the patients. And so that is the background I have. So before I begin, I want to I have titled it as Tribulations. Tribulations means difficulties. It's not easy to start what you call a longitudinal study. It's easy to do a cross-sectional study. In the sense, you go house to house and inquire, take blood, and once each person is spoken to, measured, and that's it. A lot of studies published are descriptive epidemiological cross-sectional studies. Whereas a longitudinal study is where you meet the same person again and again and again. And I had experience while as a student to do a 10-day dietary survey. My professor said, I said, why 10 days? 1 day is it not enough? You'll see. So the first day we went to the family, they all had some beautiful, with laddus and kire and everything. Second day, half went off, half went off. By third day, they had the normal food of rasam, rice, and some fried and all. So a longitudinal study will give you a more correct information about the family health and status and so forth. So, but it's not easy to formulate. And so as part of my talk, I will tell you about it. And press this. Show it there and press. Okay. So you can read it. I don't have to say it that scientific. What is research? What is research? All of you are expected to do research. In the research, there are two major questions. What is happening and why? Most of the time, you talk to the patient about what's your problem, and then you ask him about possible correlated factors like do you smoke, do you drink, do you do exercise, what kind of food you take. Because all the time as a doctor, you're interested to know why. Why did he have this problem? Many of the diseases, we still don't know the why. For example, most of the cancers, although we say that smoking and tobacco is injurious to health and can lead to association, is not necessarily causation. Okay, and you ask about the more questions you ask, the more information you have. Do you take coffee? Yeah. Filter coffee? Yes. How many times? 2 times, 3 times, 10 times. And you try to correlate the coffee drinking with the caffeine intake with whatever problem he has. It may not be true. And he may not tell you all that information because verbal questions, and this is what you'll find in the longitudinal study, that asking questions when the patient comes to you, he prepares himself what to answer. Now, all his family members also, they are told, if the doctor asks you how long you have had it, say 3 months. So they'll all say 3 months. I worked in leprosy for so many years, and you say, how long have you had this patch? Just yesterday. Oh, yesterday. Yes, yesterday. Well, that patch must have been there for 10 years. Who detected the patch? Did you detect? Did you have ice on your back? No. Wife detected. So embarrassing for both the patient and the doctor. Keep asking questions. But unless you know the actual reason, you can't treat. So essentially, research is trying to find out what and why, and okay. There are many, I'll go quickly, I don't have to actually read it. What I need to say is for you, it's more like a class before I talk about the research is that there are 3 types of studies. Any study, whatever study you do, a cross-sectional, a longitudinal, observational, which are 2 times, retrospective or prospective, and interventional or experimental. You give something and find out what happens. These are the 3 study designs. There are lots of sophistication in that and so forth. In all of these, you find that you need to find out the correlations, associations, and you need what we generally call the word control. It's not only in experimental studies you have control, but even cross-sectional studies and longitudinal studies need a control. Because most of our, what you use the word inference, is based on relative risk or relative increase in the probability of having a problem. So this control idea is the one in research matters. You have to determine what is the best control. So if you're doing a study in the hospital on diabetes and you want to know something about the correlates of diabetes, you ask about family history, you ask about his diet, you take his weight, obesity, you know that these are all correlated. And how long have you had this? What were your symptoms? Things like that. Building up to what to do, isn't it? As a doctor, finally you are a therapist. You have to decide and then ask the patient to come back and find out if he is doing better, well, is okay or not. If he has followed your advice, but his blood sugars are still high, then you know that that's not what is helping. If you have asked him to do something and he does it honestly, but still the problem persisted or increased, then you know that either he will change the doctor or you will change your medicine. That you have to do something that is there. So in this introduction, what I'm trying to say is the cross-sectional, longitudinal, the three types of studies. Is it okay? I can do that same. Yeah. When you talk about the word longitudinal studies, there are three varieties. And I would like you to learn how to carry out, because longitudinal studies are superior to cross-sectional studies. Three kinds. One is repeated serial cross-sectional studies. For example, you know the birth growth chart that you find for children that you use in pediatrics. You don't take a group of babies and follow them up right through, because you can do it, but by the time the babies are 12 years old, the data that you collected are all outdated, outmoded, it cannot be applied. So what you do to build up a kind of a growth chart is series of cross-sectional studies at different ages, the same population, using the same methodology, and then linking it together. So the medians are linked to the identified value, the value. So you get your three lines, whatever you like. That is linked cross-sectional studies, cross-sectional. If it is more suitable, more convenient, more acceptable, you will do this. And then you have what you call as a group of people with a particular characteristics. That is the definition of the word cohort. A cohort means a group with a particular characteristic. All those married on the same year, or who baptized on the same year, or swam in the same lake or Terry the same time and followed up. They have to have something common. Now here you have two kinds of longitudinal study. One, looking back and trying to find out what was the food that you had 5 years ago, 6 years ago, 7 years ago? What kind of exercises you did? What did you do? That is known as a retrospective, backward looking. And the other is the forward looking. You follow them week by week, month by month, year by year, and find out what's happening. Between the two, sometimes it is not possible for you to do a prospective study. You may have to do a retrospective, and that's what happens in the hospital. Essentially, we are trying to again answer the question, why? And so there are two factors. What happened and why? The why is called the exposure factors. And what happened is the outcome. So you start with outcomes. They're all hospital-based studies. Starts with because you have a well-documented, validated, PACA diagnosis, the outcome. And you search for why, the exposure factors. Statistics, that is a very powerful methodology called the probabilities and odds ratio. That is an estimated relative risk. And what you try to do is the case is matched with a control. Remember, without the control, a one group study today, when you send a paper for publication, no journal will accept it. One group studies are out. You need a comparative group called a control. Most of the workshops, this is drilled into the participants that must have a control, must have a control. Without a control, you cannot conclude and all that. So it happens that in one of our workshops, JP was taking one of the workshop participants, Mahesh or somebody. He went home and his friend asked him, "Hey Mahesh, how's your wife?" He said, "Compared to what?" So, this concept of control was there. You could not answer that question unless you compare. How do you choose a control in a hospital study? It has to be similar, same age group, maybe same gender, maybe same background, maybe same socioeconomic, all of those factors which are background factors. And among those, you have a wide choice. You could have sibs, you could have friends, you could have other relatives, but all of them have got a very dirty word called bias. And this bias is something which you must remove from every research, or at least reduce it. In fact, David Sackett, the famous name for you, he wrote an article in 1958, the Journal of Chronic Diseases, of 38 biases in a research project, starting from looking at review of literature all the way up. So here, choosing a control may not be ideal, may not be perfect, but you need some good control who are asked the same questions, who are put through the same process. And then you take a ratio, the probability that the case swallows or consumes or exercises this way compared to the control group, which does not do that. And that's what is called odds ratio, OR. It's a descriptive statistic. Calculate the standard error, everything for that. It is something you end your study with, the odds ratio, and you go with that. There's nothing else to do. So if you cannot do a prospective study and you don't want to do serial cross-sectional, a retrospective is the best study design that you can think of. So now I'll talk about the prospective study, where again there are these two factors, outcome and exposure. In a retrospective study, you start with outcome, find out exposure. In a prospective study, you start with exposure and find out the outcome. So much more superior because you are authenticating, validating exposure, smoker, drinker, swims in there like this, athletes, etc., etc. All of these eats this kind of food. Follow him up and see whether he gets the particular problem you are interested in. The outcome. Here also you need a control. So basically, you have exposure, no exposure, or you can have minimal exposure, 2-3 kinds of exposure, no harm. No harm in having more than one control. And follow them up and find out the occurrence. The ratio of that is again a relative risk, a true relative risk. With standard errors. Typically, you put it down in statistics books as a what you call a 2x2 table. Exposure, yes, no. Outcome, yes. You see the picture of a 2x2, 2 columns, 2 rows. A, B, C, D. And I can easily explain that ratio is AD by BC and so on and so forth. But in a retrospective study, you take the outcomes and look for exposure, yes or no. In a prospective study, you take the exposure, yes or no, and then the outcome, yes or no. And from this 2x2 tables, you can also find out what is sometimes called as prevalence risk factors in terms of various other kinds of statistics. So that there is, I will show you at the end, there's an international guideline for all of these different types of studies. And this type of study called diagnostic efficacy. In COVID, we had to look for efficacy. Efficacy is different from efficiency. Efficacy is probability that something is occurring or not occurring and all that. So this is the background I want to give you, that a prospective study, among the study designs, of course, intervention study is there. And if you look at Cochrane library website, you'll find a lot of controlled clinical trials, what use the word RCT, randomized controlled trials. It's supposed to be the best type of study, but you can't always do a RCT. Patient approval, acceptance, consent is all important. But what you can do is longitudinal studies, either retrospective or prospective. Okay, so this is the background that I wanted to give. And the Vellore cohort is a population-based. This is different. Sometimes you can do a prospective study in your hospital itself. But what I'm going to talk here, the Vellore birth cohort, is a population thing. Okay. Maybe I should press that, is it? Okay, you can read it so that I don't have to repeat it. This is what I have mentioned about retrospective studies. This is the prospective studies. And here the stated measure is the relative risk. And tell the background. Should remember that biostatistics is a very recent subject. Statistics has been there in agriculture for many, many years, centuries. But biostatistics, using human beings, these types of ideas follow up. There is no patient cooperation when you are working with plants and with mice and so forth. But here, all of those factors. And therefore, your sample sizes tend to be smaller. There is more of logistical problems when you are dealing with human beings in biostatistics. So that's what the word tribulations, when you're using, setting up a longitudinal study, there's a lot more confidence that you need to build up with the community if you want them to cooperate with you, not just once, but repeatedly over a period of time. That was the tribulation that we talked about. Okay, so now with this background, we'll move to the main study. Okay, I'm taking you back to 1960, late 60s. And a little bit of history will be important. This particular birth cohort started in 69. Before that, we had done a couple of other epidemiological studies. One of which is an epidemiological study of stroke in Indian populations, rural and urban. That was an era during 60s where the USAID used to give large grants known as PL 480 funds, USAID. And Jacob Chandy had two of those, one for stroke, Dr. Mathai, and one for cerebrovascular. The stroke epilepsy was Dr. Mathai, and cerebrovascular for Jacob Abraham. So he had two of these projects, and he offered me 1 lakh for each of those epidemiological studies, 2 lakhs, and asked me to do a cross-sectional epidemiological survey, house to house, inquiring about symptoms of epilepsy and stroke. So we took the entire Kanyambadi and the entire Guditham Taluk, entire Vellore, and we appointed a retired health inspector and a field worker. So we had experience drawing house maps, identifying the people, and then a questionnaire, asking them questions. And we analyzed it and published the data. Surprisingly, we had a lot of young women suffering from strokes. And they had quite a lot of middle-aged working group having epilepsy. These are all published and quite interesting at that point of time. This was a simple cross-sectional study, but we had experience in logistics in doing this type of study. The main problem in such studies is the cooperation, confidence, consent. Ethically, we have to get their cooperation. And all the leaders, I think CMC had a fairly good reputation. And they trusted CMC. And they said, okay, It's questioning somebody about their personal aspects. It's an invasion of privacy, no? And that is why we need that ethical consent and all that. We also need to tell them what they will say. Supposing you find something, will the treatment be free? It's another question. Another stigma part is many of them won't say. Is there anybody in your family who has fits? No, nobody has got fits. Then they'll say, what is fits? He said, this is what is fits. Ah, yeah. This boy has got fits. Then what to do, how to do, all of that. You have to be prepared when you go to the community to do a study, to look at their demands or expectations about what is to be done. Otherwise, you won't get the cooperation. Many times after the survey is over, they will come quietly and tell them, I forgot to tell you, my sister has got the problem. So you open about it. So we had a lot of that type of experience in doing these two very, very large epidemiological population-based studies. And this was done during 66. And before that, the Biostatistics department was founded in 64. I had applied to ICMR for a research project on evaluating primary health centers. And they also asked us to find out something about the demographical status of Vellore. So how to draw the street maps, house maps, the people, how to put the serial number, all of that. We had manual, no computers at that time. So in 67, when we wanted to do biostatistics, this type of longitudinal studies, the US PL 481 requires an American medical expert to be the project director. And I had asked my professor in Berkeley to be there. You also need a government of India approval before you can accept, apart from institutional IRB. When we applied to the Ministry of Health, at that time it was rejected. Why it was rejected? No reasons given. Again, Jacob Chadi said, you go to Delhi, go and meet the minister and explain what it is. Fortunately, the minister at the time was Dr. Chandrasekhar, a well-known demographer, a very good friend of Vellore. This is something you should know. It's always good to have relationships with all of those prominent people. And so I went and saw him, and he asked for the files and everything. The deputy minister came and said, why did you reject this proposal? So he said, sir, they already have 6 PL 480 projects. Oh, because of that you rejected the 7th one. So the minister was very hard. He said, CMC is doing 6 good things. Why don't you allow them to do the 7th good thing? So he scratched off and said, it's one of the tribulations. Takes time. We are a private institution. So in many instances, the government department says, we don't have anything to do with you. But then the state government requires that certificate. No, we have nothing to do with you. I have to sit with the clerk and make him type out something and say that they are part of our medical service. And so the first barrier was to cross the government of India and then get started. Then, as I was explaining to you, what is the origin? Why did this become a prospective longitudinal study? was interested more because in that area there is a lot of inbreeding, consanguineous marriages, uncle-niece marriage, first cousin marriages, and so forth. I wanted to see what is the impact of that inbreeding. I was also interested at that time infant mortality is very high, about 100, 120. In Orissa, it was 200. In Japan, it is 3. In Europe, it is 10 or 12. Maternal mortality was also very high, about 40 per 100,000, compared to 1 or 2 in other places. So that was my interest. So the correlation, exposure factors and the outcome factors were well defined. Infant mortality, perinatal mortality, neonatal, all of those maternal. What about exposure factors? I had inbreeding as one of those. I also wanted to know about their gestational age. So Dr. Rishalmi said, how are you going to get gestational age? I said, we asked them, what was her LMP? And he said, no, that's not accurate. Women, village women don't have a diary in which they say, my LMP started on February 4th. Usually it's off by a month or 2. So he said, you have to get LMP prospectively. Oh, so what does that mean? It means you follow up each woman while she's menstruating, month by month, and when she stops, you record. I said, sir, that's not possible. Nobody will give us that information. You know, these are all stigma and evil eye and all that. He said, I will not be a project officer unless you do it. So we were stuck with all our field workers. We discussed, went to the leaders and talked to them, women, and talked to them. So we'll give you the information. They said, we'll give you. So the community said they will give the information. This is the beginning of the idea of a longitudinal. Otherwise, it would have been a cross-sectional study. Just once you ask them the pedigree diagram, what's the type of consanguine marriage, find out about it. It became longitudinal because we wanted to follow up every woman. Now, this gave us opportunity to observe not only the LMP, but also the health of the mother during a pregnancy, the health of the women while they are going through menstruation. And so it gave us an opportunity, the benefits of recording both for the mother, we're talking about 69, 70, the women of childbearing ages menstruating at that time. Today, they are about 70 years old. Their children, I'll tell you the story how gradually we tried to get them included in the study. Now, how did we do it? So we come to, when you get an idea, the exposure variable, Dr. Rishalmi wanted the gestational age prospectively collected, birth weight, combination together is called the intrauterine growth rate. So if a baby is 1500 grams, small baby, all gestations was one group. From 1500 to 2500, less than 37 weeks or more than 37 weeks. 2500 or more, less than 37, but there are 5 groups intrauterine, and we correlated the 5 groups with the various mortality outcomes, infant mortality. So you see the relative risk of small babies, small for date babies, large for date babies in relation to infant mortality. But we could also get neonatal mortality, perinatal mortality. We also knew about their growth parameters in terms of weight, how the weight increased, how the length increased, and so forth. So once you cross that big hurdle of having a prospective visiting, observing week by week, and we thought 28 weeks. No, the menstrual cycle and textbooks talk about 28 days, 4 weeks. No woman had 28 weeks. 29 or 30 or 26 or 25, 26. So when we planned the visit every 4 weeks, it didn't work. So we made it every 5 weeks. So we knew what we wanted. The exposure factors, the process factors, and the outcome factors. So now I'm going to talk about the 6 building blocks that you have. You can get a copy of this if you like and give it to them. Okay, this is what I've just mentioned. And okay, these are the objectives of the longitudinal studies. Started with only the first one, but the opportunity was there. The maternal mortality and morbidity was largely due to eclampsias. And the hypothesis was if you monitor the diastolic, during the second trimester, the diastolic should go down, whatever reasons, and then come up. Women who do not show the dip are more likely to have eclampsia. That was the hypothesis. So we got these aneroid sigma-manometers and trained the field workers on that, follow them up. So that was the second objective. The third was in relation to inbreeding. We talk about that in terms of Gudiyatham Taluk and Tamil Nadu compared, and Andhra partly is famous for consanguineous marriages. Not so much Kerala, not in Maharashtra and other places. Some parts of the world are very popular for marriages among relatives, first degree relatives. So you talk about incest, but the close next to incest would be uncle-niece marriage. It looks as though there's a big age difference. It's not. In a family with large number of children, having a girl baby is a tragedy. Your last week's paper talked about the dowry problem. The father, when he has a girl baby, the patients, the hospital are given peanuts. When they have a son, they give laddus. It's a different gender bias. But when the first girl, and usually she gets married, most of the father's property goes with the girl. Now, the father continues to have children, like my family. And when you have a boy, and then this girl already is producing children, and she has a girl, that boy and the girl, that's uncle-niece marriage. So when such thing happens, the money that went to the girl goes back to the boy. So there are about 7 theories about the consanguinity, why it is popular, and there are many other social reasons, like why do you prefer? And wherever a child is born, immediately they would know Moram Apply. There are 25 first cousins available. And the reason is a known devil is better than unknown angel. So here we know that his family, the background, everything. So it's better to get married to a relative than get some stranger who we don't know what it is like. In any case, the question was the consanguineous marriages, 80% of the marriages in Gudiyatam Taluk were consanguineous. 80% at that time. Now it has come down. And when you have large families and there are any number of first cousins, uncle nieces available, the family usually chooses the best first cousin to marry. Interestingly, this objective is a very, very important kind of revolutionary objective. I'll tell you about it later. So this was the third objective. The fourth and the fifth are related to the mortalities and so forth. So setting up of a longitudinal study, there are 6 major building blocks. The first one is what area? Where will you do your study? Which is the best area? What do you mean by best? In terms of cooperation, in terms of representativeness is very important. Can you generalize from that population? Will they continue to cooperate and help you not just once, twice, not first year, second, third, fourth, fifth year? All these considerations were there for choosing an area. And I'll show you the map of Gudiyatam Taluk and Vellore and so forth. And we searched for it and we worked out the minimum sample sizes for the statistically valid significant results. And we took 1/3 of Vellore. Population at that time was about 140,000 into wards. You know, most of you would know Vellore, Thottapalayam, Saidapet, Valapadi, Kaspa, and so forth. So we took an area sampling, about 1/3 of about 40,000 population of Vellore. That is urban or semi-urban. And then we looked at the Gudiyatam Taluk. And Gudiyatam Taluk, you see, Vellore district is the northernmost part of Tamil Nadu. Next to us is Chittor. So the Vellore district had several Taisals or taluks, and Gudiyatam Taluk was the northernmost, and there were 4 blocks in that: Katpadi, Kevikuppam, San Melkuppam, and Alkum something. And so among these, randomly we took Kevikuppam. Kevikuppam is Keel Vali Tunayar Kuppam. And it's a Tamil thing. That had a population of about 100,000 or so. Very large rural population. So we have decided on the Kevikuppam rural and Vellore. Then we had to list out what data you wanted. The second major item is what data you want to collect. If you are too ambitious, then you'll have a lot of data. How to get the data is the next problem. Essentially, we focus whenever you're doing research according to the objectives. What are the exposure variables properly collected, subgroups and all, and the outcome variables. So infant mortality can be subdivided into perinatal, early neonatal, and post-neonatal and so forth. You can also look at the measurements of the baby. So we took 5 measurements at birth. We took birth weight, birth length, we called it crown heel, We also folded the leg and crowned rum here to rum. Chest circumference and head circumference. These 5 measurements, within 48 hours of birth, we got it. So we have the menstrual cycle and when it stopped. We have the birth date, so we know the gestation. And we have the birth measurement. Now you follow up the baby till 1 year is completed. In between it dies, you record it. So the data we need about the follow-up of the baby. Every woman, when she missed a period, we used to have a pink form when she was menstruating. When she missed a period, a new form of pregnancy was opened. Every month, the woman was followed up till the pregnancy terminates. And when the pregnancy terminates, we had a third form, different color for the baby. So essentially, we had for routine follow-up 3 kinds of forms, structured, date-wise, and we had to decide on the serial number uniquely determined for the whole population. So before that, we had our experience of getting the street maps, the house maps, and the serial number of the household, every married woman, and the child of that woman. All manual. Today it's, I think, a computer and fantastic. But at that time, it's all manual, manually done, manually organized and do it. I'll tell you how we did it, but this is the situation that you have. So essentially, please tell me when I should stop. So the woman follow-up, the child follow-up, and then husbands also, the family also, something about diet, whatever we thought was relevant, exposure factors, we got it. See, basically, when a baby is born small, very small sometimes, it takes on a color of slightly blue and slightly yellow, jaundiced and asphyxiated. The women called it chavapu. We didn't know what was chavapu. What is the chavapu? We have kept it in the garage. Oh, there's a pot with straw. The baby was put in the straw to generate heat. Oh. A lot of ants were there. Chavapu. No ant will come. They had their own strong beliefs. And then what do you give the child? Donkey's milk. Because donkey's milk had a much higher protein content and heat producing. So you could see fellows running after a donkey, maybe a male donkey, but he will still run after that to catch the donkey and get the milk. In spite of all that, the baby survives. So we are a very hardy generation. What Modi is talking about, we are very strong. Whatever Trump may do, it doesn't matter for us, all the tariffs. So question of, we had a pediatrician, Dr. Kulasekaran, local chap. He went to find out how the barber woman delivered the women. And they delivered with their own tools and the umbilical cord was cut. How? They had a razor blade. Rusted, BD ash, you wipe it in that, cut it, no problem. So they have their own reasons why there is no sepsis and all of that. This we have to record. I mean, in a research project, you don't interfere. You don't tell them this is good or this is bad. Accept what it is and make a note of it. So all of these practices during pregnancy and during the child, we did all that. So it's all narrative, So all written down on these sheets of paper. So what did we do? Eventually, I'll tell you. After what data we have to collect, how to collect it. The next question that you have will be who will collect this data? So we had to think about the field investigators. Definitely women did not have very high qualifications, maybe SSLC, maybe literate people, maybe A&M, maybe somebody who had some health experience, somebody who worked in CSI or some other place. Wives of many of our staff, they all were field investigators. They were all trained, oriented, willing to do hard work. It's always walking only, no? So each woman was given about 1,000 women to follow. We calculated and said each woman can interview about 10 women per day properly, and 20 days, 200. So over a period of a month, 4 months, she can cover that area. So each field worker also was given a sling bag, and we got the weighing scales, the domestic dietary weighing scales from Sweden with a special pan made to put the baby. It should get into the sling bag. We made an aluminum board graduated where we can get the length, crown heel, crown drum, and measuring tapes. We also aneroid blood pressure instrument and all the stationery, pencils, paper, peppermints, chocolates, whatever else it is needed to get there. So each field worker had that bag and she went around. 5 days a week field work. Saturdays we all meet, discuss the results, plan for the next week. And each 4 or 5 interviewers, there was a female supervisor, usually a lady health visitor, a public health nurse, who did a 5% subsample check for all the measurements. So then we also had 5 men coordinators to talk to the men, to the leaders and so forth. So we had 2 groups in urban area and 3 groups in KV Kuppam, Latteri, Vadagantangal and KV Kuppam. 3 women supervisors, 3 men coordinators, 2 women supervisors. All of us used to meet on Saturday mornings and discuss all that they did the past week and plan for the future week, any problems sorted out and so forth. Any leaders had any question, he was brought to us. We also had to get contact with the departments in CMC, the pediatric department, the obstetric department, medical department. And we had a special referral form, said if anybody comes to this form, properly diagnosed and free treatment for them. We did that. So all of these records were all manual, and we had a family folder. And what happens in our Indian community, I don't know in Kerala, but a girl has to go to her mother's place for delivery during a 7th month or something, and then come back after the first month. We also have to do some arati and puja and all the rest of it for these girls. And a lot of us told us, nobody will tell you when she stopped menstruating. Nobody will tell you anything. And weighing the baby, so many times, oh, the baby will die. So they objected to weighing the baby. Naked, oh, God will see the baby will die. So the baby used to have a common or all the urine and stools and that. We had to make allowance for that. So when you work with the community, you have to go with what the community practices are. And but we convince them about the need for it. The pan is so cold, and the baby, she'll get chronic bronchitis and all that. So we have to have a blanket before we put the baby on the wings. So many tribulations as part of the whole. But we did it. We did the whole thing, collected the data. Dr. Rishalmi didn't believe all this. He said, how do you know she's a married woman? I said, they all have a thali. You pull the thali and so. How do you know she's stopped menstruating? How do you know she's menstruating? The local practices in terms of, at that time there are no tampons and all these kinds of things. There's some rags and cloths and stuff. We learned a lot. The community told us they learned a lot. And the foreigners, experts, when they came, they learned a lot. So the data was collected, tabulated Saturday mornings, put into various kinds of reports, and we reported to the community every month and got their feedback, got their suggestion, and then we continued the study. And what happens is that after the baby is born, the woman gets into what's called lactation amenorrhea. At that time, she doesn't menstruate, right? But some of them even got pregnant during the time. So we asked the field workers, what happened? What it was, she's sitting all the time, every time we visit. We didn't know she was pregnant. So there are instances where the amenorrhea is not really, there's a community belief. Once she's breastfeeding, the will not conceive and all that. Now, this was an era, if you remember, 1967, 69, of family planning was being pushed by the government of India. There was a lot of resistance by the public to the government program. And they thought our workers are also family planning workers, spies and so on. So the field workers came and said, sir, they are not telling us all that. I said, you tell them, in our study, we want a baby. If you don't produce a baby, we lose our job. So basically, building the confidence of the community. You know what happened towards the end? The community asked our people advice on family planning, not the government workers. And there was so much of camaraderie. We met. Even now, when you go to Vellore or Kaspa, they'll recognize you. And they're very happy about what you have done and so forth. So this was the way we got the data, analyzed it, and presented. And we had review meetings and discussion on that. Now, coming to the inbreeding part, we found that there was no difference in congenital malformations between women who are consanguinely married and not. No difference. Mendel, with his P experiment, showed that if you have a allele which is lethal, you use the binomial formula A squared plus 2AB squared, the B squared will become lethal and fatal and die. True. What had happened was that over a period of centuries, this mating of consanguineous was, according to the famous Hardy-Weinberg law, was called non-random because it's not random with anybody. It is deliberately choosing a first cousin or an uncle niece. So a non-random mating, if Mendel's law is true, and each cycle that particular offspring dies, does not survive or does not reproduce. But our couples are very strong people. They go on having children. So large families, according to the random mating, there are some who don't have that. Then we found an article by Darlington in 1960 who said that the long-term effects of inbreeding are different from the short-term effects. Long-term effects would mean that over a period of time in that community, all the bad genes are washed out. Every time they have washed out. So genetic counselors were a bit surprised and they checked up on all this. But this is the situation. Large families, close inbreeding, results. Now it will be different because family sizes have become smaller. You don't have that many first cousins. And also the genetic pool has changed over a period of time. But that was an important finding. It was published in Annals of Human Genetics and so forth. So that's the 5 conditions we are talking. We mentioned about the urban and the rural samples. And this is a map of Vellore district. You could see that yellow mark, KB Kupam, and the Vellore district. This community engagement and sample size determination, as you all know, that's an important part of it. So I mentioned about all of the data that we need to collect and field workers and the tools. The other thing was Dr. Rishalmi did not want spring balancers, wanted beam balancers. So that's why we had to get the domestic dietary balance beam. And the tape also but to make sure that it's not elastic or anything. What had happened was by the time 65, 67, we never had computers. No? But what we thought of, there were people using what's called as cope chat cards, that is 5 into 8 inch cards with holes around. And you cut off the holes and put an eating needle and take it out. You can count the number which is not cut. We modified that and called it colors instead of holes because it's cheaper to print here the same size cards with the edge marking space, 4 colors, red, blue, green, and brown or black. And those colors indicate male or female, age group, yes or no, all of them, all around the card, this side, that side. And we use those edge marking cards in many of the hospital research. I remember Dr. Paranjoti had to have a research project, and this edge marking cards, during that time, she had used Marthan and Mani to do all the coloring. That the interns were doing all that. But then towards the end of that project, Dr. Feldman helped us to get a IVM, 80 column punch cards. So we punched card, puncher, verifier, and took it to Madras, to IIT for analysis. The programmers were very important at that point to write the program bracket and all that. We used to put up a lot of data with the and wait there in IIT, and you get a small strip saying appended. Appended means abnormal ending. What happened? Something wrong with the program. You opened the bracket but never closed it. That was the only mistake. things like that, tribulations. We finally got that sorted out. We're very happy with the IBM machines. Now, I can't even think of it nowadays with the computer days. So, but that came towards the end of this research. We managed even with. In other words, it's not those things that are important. What is really important is the way you handle the community to get the cooperation, the accurate data that you want. And this were the, what happens is that once the 1 year is over and we are following up the woman, she produces one more baby and this baby goes up. So we got some grants from ICMR and other places. And then the USAID again gave us a major grant to follow up the adolescents. And that's how we were able to follow them up. It's too small, we'll get it printed out. These are some of the results, the key findings. And these are some of the research outputs. Naturally, we have quite a lot of staff. They were given the chance to write up. Many benefits that I mentioned, unexpected benefits. And the KV Kuppam block was chosen by Delhi as the RUSA. So we're very happy that that community got the benefit because we had very good data for that block. And then the British Heart Foundation and the other agencies picked it up for fetal origins because we have accurate data during pregnancy, blood pressures and height and weight and various chronic diseases in terms of adult disease. And the studies are still going on. I think people are still working. And I think the latest paper, saw some references, and the latest paper by Padma, the Royal Ophthalmology Journal. She tried to look at some opacities of this using this birth form. This is a photograph with Erishalmi and all of this field workers and statistical staff and so forth. Okay, thank you.
Who was Dr.